Our next speaker is Dr. Michelle Yong. So thanks, Michelle, for joining us from Melbourne. So Michelle's a ID physician and postdoctoral research at the Peter MacCallum Cancer Centre and the National Centre for Infectious and Cancer at the University of Melbourne. And Michelle's research focuses on CMV and viral infections in transplant and immunocompromised hosts. In particular, understanding the CMV-related transplant outcomes and CMV-specific immunity. And Dr. Yong holds several competitive NHMRC and MRF Australian grants. So thanks very much, Michelle. Michelle's talking about current and future therapies for CMV disease. And if you want to put questions in the chat as we go, we can answer them at the end. Thanks, Michelle.
Thanks, Andrew, and thanks for that kind introduction and the invitation to speak. So, thank you very much, Chris. Hard to follow you, but I'm going to be talking about the current and future therapies for CMV disease. And like you, Chris, I'm sort of excited to be in this area because there have been a number of changes and therapeutic advances in this area. So I'll be describing some of the burden of CMV, looking at the current old antivirals, spending a short time on that because there's lots to discuss with some new antivirals in the CMV space, and also the new frontier of immune therapies and third-party related CTLs, and hopefully some time to look at when and how to use this, demonstrated by a couple of our clinical scenarios. So I'm going to again start off with a bit of virology. So Cytomegalovirus is the largest member of the beta human herpes virus type 5. And it's a double-stranded DNA virus, which is one of the largest viruses around, with more than 200 open reading frames, made up of a layer of sort of viral proteins, and the most common or one of which is PP65, also PP150, as well as some glycoproteins. And it's not commonly transmitted as a respiratory virus, so I'm a bit of an outsider in this symposium, but transmission is usually through infected body fluids such as saliva, placenta, sexual contact, blood transfusion, but I'll be concentrating more on the transplant group, so a select group who we know are at high risk. And after primary infection with CMV, usually as a child or young adult, CMV establishes a lifelong latency and is present in a very small but significant population of the mononuclear cells, with the ability to reactivate in times of stress, inflammation, or iatric immunosuppression, such as transplant. So this is sort of I put this in a global view of CMV, and the CMV seroprevalence in Australia here is around 60 to 70%, and we know this through adult blood donor seroprevalence. And population studies show that it's inversely proportional to socioeconomic status and increases with age. But given that I work in the transplant field and a lot of our population are now born outside of Australia, just bearing in mind that within our neighbouring region, that particularly in the Southeast Asian region, that seroprevalence is up to sort of over 90% in some cases. So why is this important? Well, I work a lot with hematopoietic stem cell transplant recipients, and I just want to highlight that these patients go through such intense periods of immunosuppression that it's almost inevitable that they will have an infectious complication. So 93%, of which CMV viral infection is the most common at 75%. And this contributes significantly to the morbidity, not only through direct tissue invasive disease, but also the treatments that we're currently using is associated with quite profound toxicities. There's also the element of CMV indirect effects and whether it leads to sort of other opportunistic infections. And no doubt having CMV as part of your complication of a transplant period uses up a lot of resources, and we know that these patients spend a much longer time in hospital using up our precious resources. So on the right here is this pie chart. We shouldn't be using pie charts, but just to highlight that 21% of overall deaths which occur in this very high risk group is related to infection. So what do I mean by CMV disease? And some of this terminology has changed over the few years. So by this, I mean end organ disease, of which I can report is less commonly seen now because of our preventative strategies. And it is of significant morbidity in the stem cell transplant group, but also the late solid organ transplant group. And we've had trouble with patients having had a renal transplant even 15 years ago, presenting with quite severe CMV disease. As I mentioned before, it's one of the most common infectious complications. And the epidemiology of CMV disease has changed. So it used to be pneumonitis was the most common manifestation, as demonstrated sort of by this CT up the top there. But we're seeing more and more CMV colitis. And the reason this is sort of somewhat important because we need long duration of therapy, and with current treatments, it's very toxic. And we shouldn't forget that there's still quite a lot of high mortality associated directly with disease. But what about viremia without end organ disease? And this has been a sort of a controversial area for some time until this landmark paper was published, which showed in a cohort of over 900 stem cell transplant patients, which looked very carefully at each level that patients had CMV viremia, and did find an association with increased mortality with the presence of CMV virus, even at levels as low as 250 international units per mil. And I touched upon indirect effects. So this was a study I looked at which associated the risk of CMV reactivation with subsequent risk of invasive fungal disease. And not only has CMV been associated with indirect effects in terms of other opportunistic infections, so bacterial and fungal, but also in the solid organ transplant group, things such as ischemic heart disease as well, and this sort of pro-inflammatory phenomenon. And the reasons for this are unclear, and a reason to do more research is it's unclear whether it's related to treatment, ganciclovir itself and neutropenia, whether it's related to the virus or whether it's immune related. So what are the current and new CMV treatments? But before I get onto that, I just wanted to go through a number of concepts of this is, we know we have an at-risk patient, so there's a number of strategies that we're using to prevent CMV. And the first one is universal prophylaxis, whereby anyone we deem at risk of CMV infection is given antiviral upfront before they reactivate, often for the first 100 days or 3 months during that transplant period, to prevent antigen and to prevent CMV for occurring that sort of early transplant period. And in that setting, we often would like to use an oral agent such as valganciclovir and lutimavir, which I'll talk to you more about. But some of the downsides to using this kind of strategy are that there's some toxicity associated with what we're using, that potentially we're unnecessarily giving treatment in estimated 65% of these patients who didn't need it in the first place. The theoretical risk of occurring viral resistance if patients are intermittent with their prophylaxis. And of course, this is really costly to our health system. And then what happens after you come off prophylaxis? Well, undoubtedly you get a rebound of CMV and then the occurrence of late CMV disease. And it's argued that this may in fact cause more morbidity because it's often missed and occurs at a time when they're less intensely monitored. So the other strategy, which is a bit less popular, is a preemptive monitoring strategy, whereby we're more targeting and judiciously using our anti-CMV agents with those where we're sort of monitoring and seeing a detectable level. However, the downsides to this are that we know that CMV disease can occur in the absence of plasma DNA, that by the time you perform a test, wait for the PCR and get those results, there are often delays in treatment. And we still have not got an ideal or optimal viral threshold on when to start treatment. So what are the current CMV antivirals? And I've listed them here, and they've been around for 30 or 40 years. Ganciclovir, the prodrug valganciclovir, foscarnet, and cidofovir. So very briefly, ganciclovir or valganciclovir is our first-line treatment. It's a nucleoside guanine analog, which inhibits the CMV DNA polymerase. It does require renal adjustment, so it is a bit tricky, particularly in the renal transplant group. But the main limiting use of GAN or Valgan is that its neutropenia is very common and occurs frequently and over time. And this is already a quite immunosuppressed population at risk of other infections, so obviously this isn't great. And ganciclovir use itself has been associated with invasive aspergillosis with a hazard ratio of over 13. Other CMV current treatments, second line is foscarnet, which unfortunately can only be delivered intravenously, carries with it a lot of nephrotoxicity and severe electrolyte disturbance. So again, uses up a lot of intense resources. And the third line agent is a drug called cidofovir, which is given a bit better, only IV weekly. But again, nephrotoxicity is the main reason which it's not ideal. But now we come to some of the new agents which are around. So maribavir and letermovir. So I'll start with letermovir. Which is a novel anti-CMV agent which binds specifically to the CMV terminase complex rather than the polymerase as the older drugs do. And this is a very specific terminase to CMV virus. So therefore, it has minimal myelotoxicity and interrupting the late stage of viral replication. And the great thing is it's available in oral and IV, but the caveat is to the Australian audience is that although it is available, it's not currently funded in Australia, but in the rest of the world and in the rest of the sort of allogeneic stem cell transplant world, it's considered standard of care for primary prophylaxis in high-risk CMV recipient positive. And the reason is due to this landmark study by Francisco Marti, published in the New England Journal 2017. And this was a study which randomized patients to universal prophylaxis with letermovir versus placebo, which at the time was preemptive monitoring, with the endpoint being clinically significant CMV infection defined as needing treatment. So you can see in this cumulative graph here that in the dark line, the letermovir for the first 100 days that patients were on really suppressed the rates of CMV infection, with a small upward incline after prophylaxis stopped up here. But compared to placebo, there was a significant difference, and the primary endpoint was reached at, which was week 24, showing that letermovir clinically significant CMV with letermovir was reduced at 37.5% versus 60.6%. And this wasn't the primary endpoint, but an interesting result was all-cause death. So at week 24, which was the primary endpoint, there was a statistically significant difference in all-cause mortality in patients with letermovir, only 10.2% of deaths versus 15.9%, with a p-value of 0.03. So this wasn't a primary endpoint, but we were finding not only did it reduce clinically significant CMV, but also had a somewhat unexpected advantage of reducing death. At week 48, however, there was no statistically significant difference, but there was still a numerical difference. Moving on to the next new drug that's been around is maribavir, and the indication for maribavir, or the space that it has, is really for the resistant or refractory CMV. So it's a benzimidazole riboside, which is currently FDA approved and available overseas, but again, not available yet in Australia. And it works through 4 different mechanisms to inhibit DNA replication encapsidation, viral capsid, and UL97 kinase. And a big study was published late last year in CID, which was a randomized study looking at resistant refractory CMV in the transplant population. And it compared maribavir versus investigator-assigned treatment, with the primary endpoint being CMV clearance at 8 weeks. And this was much better or improved with maribavir at 55.9% versus only 20.8% reaching that primary endpoint. And can I just those numbers don't look great for a CMV clearance study, but these patients are highly complex transplant patients, often with a lot of comorbidities. So that's why even the primary endpoints aren't very high to achieve clearance. The most striking thing as well with this study was the tolerance of maribavir versus standard treatment. So neutropenia with the maribavir drug was much lower at 9.4% versus 33.9%. And undoubtedly as well, renal impairment when compared to foscarnet was also significantly lower. So some good results there, but just to point out that if you are treating or have a patient with resistant refractory CNS disease, that maribavir does not cross the blood-brain barrier and shouldn't be used for CNS disease. Some other exciting area to talk about is CMV-specific T-cell therapy, which is a very amazing growing area of interest, but not yet standard practice. And the way I describe the CMV-specific T-cell therapy to my patients, at least, is that it's an infusion of primed T-cells or a souped up sort of power boost against CMV-specific with CMV-specific lymphocytes to try and clear your virus, given that we've immune suppressed you so much. And some of the indications with which it's been shown to have some good value is in the prophylactic space, but also patients with persistent viremia, resistant virus, or severe CMV disease. And the really great part of this is that you can prime them against not only CMV, but also other viruses, CMV, EBV, and adeno, which all the patients that I see in the transplant group are at risk of. So just one study to highlight how effective these may be. And we're very lucky in Australia that we have, experts in Queensland and New South Wales, David Gottlieb's group, who are leading the way internationally in this field. So Barb Withers and Dave Gottlieb published this study, which looked at third-party multivirus CTLs in patients with very difficult persistent viremia or disease. So they had 30 patients, the majority of which were due to difficult CMV, but also EBV and adenovirus. And this was performed over 7 centres in Australia and New Zealand in both adults and paediatrics. And the primary aim was really to assess safety in this group. However, they did find that overall response, defined as reduction in CMV virus or the virus of interest, was really great at 93%, with complete response being shown at 12 months to be 76%. So very good, effective, and sustained in a small group of very highly complicated patients. And with regards to safety, outcomes were again very good. So these were patients infused at a median of 75 days after transplant. They'd all had over a month's worth of antiviral treatment with no effect and all those associated toxicities. And it was well tolerated, with the main concern being whether these infusion of these cells would trigger acute graft versus host disease. And importantly, the infusion related and resulted in very durable responses with no recurrence. So overall, these CMV CTLs or multiviral third-party CTLs seem to be well tolerated and safe, and can be infused with as little as 1 to 2 out of 6 HLA matching, and is effective in both treatment and prophylaxis. Single infusion may provide a sustained response, but there's only some clinical trial work at present. So we need more real world data, high dose steroids and graft versus host disease. And we're also looking at using this concept of third party prime CTLs in the setting of other respiratory viruses such as SARS-CoV-2. So just in the last few minutes, a couple of cases just to demonstrate how we might use some of the new antivirals. This is a 67-year-old haplo allogeneic stem cell transplant, recipient positive, donor negative, who undergoes a first CMV reactivation in the setting of graft versus host disease and has a very rapid CMV viral rise to 25,000 international units per mil. So he started on first-line IV ganciclovir, but it fails, the viral load fails to reduce appropriately, and he's switched over to foscarnet whilst awaiting a genotype. No mutations are identified, and so he continues on foscarnet to try and achieve 2 consecutive undetectable viral loads. So the question comes as what can we use as secondary prophylaxis? And oral valganciclovir is prescribed, which would be standard of care. But the viral load again fails to achieve undetectable levels. And then in this setting, and I've often asked, should I switch to one of the new drugs, letermovir, which is orally active? But the answer there in this setting is no, that letermovir hasn't been approved to be effective as secondary prophylaxis in the setting of ongoing viremia. So should only really be used as primary prophylaxis. Neutropenia develops in this patient on valganciclovir and his dose is reduced. And then colitis is confirmed on biopsy, and now he develops the typical mutations showing resistant CMV. And so in this setting, the next therapeutic options would be to try and access maribavir, which is the new agent. And we do that as part of a clinical trial, but it's available through compassionate access at the moment, and it clinically improves. And just the second case is a young male with ALL who undergoes umbilical cord transplant and has, again, CMV colitis confirmed and started on standard ganciclovir. However, he's admitted to ICU and changed to IV foscarnet because it seems the diarrhea is getting worse. And not surprisingly, on IV foscarnet, he develops renal failure and has clinically refractory CMV disease due to refractory clinical and poor resolution of the clinical sort of syndrome, but there's no plasma virus to send. And so we're often in this sort of situation where we can't really follow a plasma viral load. So what would be his next therapeutic options? Well, 20 years ago, you might have reached for CMV, IVIG or immunoglobulins, but that's no longer recommended as there is no good evidence to show efficacy in this setting. You could go to cidofovir, but he's already got some renal impairment, so no doubt that would be made worse with cidofovir. Maribavir, again, would be good if you had access. Some of the older drugs, which I haven't talked about, which you may have heard, is leflunomide or artesunate, and they're not anti-CMV agents, so are an option if you're stuck in a corner. But now we've got maribavir and also third-party specific T cells, and so he was given third-party specific T cells and did very well. So to conclude, there are a number of new agents, anti-CMV agents, so the maribavir and letermovir, which now give us some extra options in the universal prophylaxis space, as well as the resistant refractory space. And so the next horizon is sort of trying to optimize the current CMV agents as well as these newer agents. And I think we'll see a shift towards universal prophylaxis with more tolerable agents such as letermovir. I think host CMV immunity will become more important, and monitoring this and using as much information available together to try and come up with individual risk strategies to try and individualize treatments and reduce toxicity. And third-party derived CMV T cells is again a very exciting field because we could potentially avoid all toxicity from drugs and use infusion of these CTLs with good efficacy, durable and well tolerated in the setting with or without antivirals. And there are some ongoing randomized studies looking at this. So with that, I just want to thank you very much for listening to me and invite any questions, if any.
Thanks very much, Michelle. That was terrific. Just feel free to put questions in the chat room. Otherwise, is it questions from the floor here if needed. I was interested, those most recent drugs like Maribavir aren't currently approved in Australia. Michelle, is that something that's going to change, or do you want to just, and Letermovir as well? Do you want to have any comment on that?
Yeah, no, hopefully. So it's sort of, we're a little bit behind, but I'm hoping that they will eventually come to us and be approved. But if you do currently have a patient stuck, you can go through the company and if they meet the criteria resistant refractory Maribavir, they will be able to access that for you. But very hopeful in the future that they will be available. But as you know, they're going to be costly, and it's weighing up cost-benefit, cost analysis for that.
And so when they're used, say, I'm trying to pronounce it now, Letermovir, so you said that's for primary prophylaxis. So like in North America, for example, in Europe, would that be sort of standard for people after stem cell transplant?
Yeah, so my colleagues in the US and particularly in the US don't see CMV in that early stage anymore. Whereas here we're still using preemptive therapy. It's become standard of care. So we will apply to have that reconsidered here in Australia and have that accessible to our patients.
Here's a final question from me, Michelle. It relates, in Brisbane, we get excited about therapeutic drug monitoring. So that's a bit of a parochial question, but in terms of TDM for ganciclovir and so forth, do you have any comments? And you've spoken about drug-related toxicity. Is there any sort of evidence to guide that, or would you ever do it? People with renal transplant patients, etc.
Yeah, no, it's like you planted a question there, Andrew. So I took out the slide. So I'm really interested in therapeutic drug monitoring as well. And together with your CRE, we do have a project going with ganciclovir TDM in the stem cell transplant group, and trying to figure out, together with collecting of PBMCs, where that toxicity, that neutropenia toxicity lies. So hopefully I'll have more information. I don't do it routinely in my adult population, but we have a study going with you guys in a research setting. So I hope to tell you more.
That's great, Michelle. We'll get you back next year for that. That's great. Look, I don't think there's any other questions, but it was really a fantastic talk and I learned a lot. So thanks, Michelle, for giving up your evening. I know it's an hour later there. So thanks very much for hanging around.
Pleasure. Thanks.